So I'm talking about septic arthritis in children and the sequelae. And making the diagnosis, as already mentioned, is the most important part of this. So septic arthritis is a predominantly condition affecting children under the age of 4 years of age, and up to 50% of those cases are under the age of 2, so they're very susceptible children. The location, the hip accounts for 40% of the cases, 30% in the shoulder, 50 or 10, so that's the normal spread. But the hip is the one we worry about the most because it's got the least resistance to infection. If you look at the difference between septic arthritis and osteomyelitis over the years, you can see that the septic arthritis definitely predominates as the osteoarticular infection of the young. The risk factors have been mentioned: immaturity, immunosuppression, inoculation, which might be from umbilical catheterisation, venous access, or even heel pricks for doing PKU testing. The etiology is generally haematogenous with transient bacteremias, which we're all exposed to every day when we clean our teeth. Seeding from a septic focus is less common, but it can be a cause. And then there's obviously the extension from an adjacent focus of osteomyelitis that perforates into the capsule where the metaphysis is intracapsular. Occasionally there's direct inoculation from a surgical penetration or trauma, and those direct inoculations from trauma can often have unusual organisms and even fungal infections. If we look at the spread of organisms, Staphylococcus is common across all age groups, but there are specific organisms at different ages: the group B strep and gram-negative bacilli in the young, the group A streptococcus, Kingalia kingae, and in the unimmunised, the Haemophilus influenza in the 1 to 5 year olds. Older groups, we have to then start to be suspicion in adolescence about Neisseria gonorrhea. The most important thing I can tell you is that you need to know your local microbial environment and what's common and what's the right antibiotic to use. But you need to be aware of septic arthritis in the penetrator joint and that you may be infected with an unusual organism. There is this group of organisms known as the Hackett organisms, which is Haemophilus, Actinobacter, Cardiobacterium, Encanella, and Kingalia kingae. These are organisms that actually do account for a large number of our infections in the under 4 years of age, but because they're difficult to culture, we don't often encounter them, so you have to do prolonged cultures and enrichment broth. Kingalia kingae may account for up to 40% of septic arthritis in the under 2-year-olds. Haemophilus influenza obviously has become less common with vaccination. So the diagnosis is these 4 things: the presentation of acute onset joint pain, irritability, or pseudoparalysis in the infant, symptoms of sepsis, history of trauma or recent infections, but be aware of the masked symptoms from previously given oral antibiotics, and check the vaccination status. The clinical examination is obviously of constitutional symptoms, but infants may not be febrile. Joint irritability, active range is reduced, pain on passive movement, the limb assuming an open packed position where the tension in the joint is reduced, and effusion, tenderness and warmth, and an examination of adjacent joints. We've heard about the laboratory investigations, that they may not be completely reliable. ESR is often normal in early phases, but CRP is the thing that we look at for acute raises and strongly associated with sepsis if greater than 20 micrograms per litre. And blood cultures are always needed to be performed, but won't be positive in all cases. The predictive Cocker criteria have been mentioned, and if all 4 are present, there's a high suspicion of septic arthritis, and CRP is an independent risk factor when it's greater than 20. So what are the imaging? Plain X-ray doesn't have a huge role in septic arthritis, but you might see some changes in soft tissue, swelling, periarticular osteopenia, and loss of tissue planes. Sometimes a joint will look like it is subluxated because of increased fluid in the space. And once you start to see rarefaction and focal sclerosis, it's been going on for far too long. The ultrasound needs to be comparative. You can't tell really the difference between effusion and infection, and it's quite useful for the hip and the ankle. Bone scan is something that we certainly used a lot of, and it's useful in some cases when the diagnosis is uncertain. In the hip, it's got a predictive value of 100% when there's low uptake, i.e. a cold bone scan, and 82% when there's a high uptake, the hot scan. And that's predictive of both osteomyelitis and septic arthritis. If the distribution and uptake is uniform within the joint capsule, it's more likely to be septic arthritis, and asymmetric uptake is more likely to be osteomyelitis. MRI is probably, from what I can tell, is probably more easily available in India than it is in Australia because it's highly regulated, and it's generally not been our first line investigation, but it does mean no radiation exposure, but in children it often requires a general anaesthetic to get the appropriate views. And it's useful for identifying areas of residual infection and defining associated osteomyelitis. So when it comes down to treatment, these are the main things, and I'll talk about those. Splintage is useful to protect and rest joints. It decreases pain, reduces swelling, and prevents contractures, particularly foot and ankle, holding that foot at a neutral position. Joint aspiration and washout go hand in hand. Aspiration to take the cultures first, and then a surgical emergency for the hip for an arthrotomy addresses the effect of chondrolysis and ischemia, and it should be an open procedure with a capsular window, leaving a drain behind. When you take the aspirate, sometimes very simple cultures are taken for that, but I think it's very important that an EDTA tube is used to get a cell count, a gram stain slide, and culture in a variety of media using culture bottles. On a joint aspiration, if the white cell count is greater than 50,000 and 75% of polymorphs, that's diagnostic for septic arthritis. But we need to remember that 35% of our cases will have a white cell count less than 25,000, so you can't rely on that. And our culture results again vary with how good they will be for making the diagnosis. But before we'd even received the cultures, we'll have started treating with antibiotics. So generally it's empirical therapy after joint aspiration, and again, practices will vary from place to place, but our practice would be parenteral antibiotics for 7 days for an acute septic arthritis, and then oral antibiotics provided the clinical and laboratory response was favourable. Our general choice is either flucloxacillin or cefazolin until the culture results were obtained, and then 2 to 3 weeks of therapy, only terminating when the ESR and CRP have normalised. Now, the one thing that is raising some interest is the use of anti-inflammatories, both non-steroidals to reduce the symptoms and increase joint motion. But recently there's been a number of papers presented that have pointed out the advantage of adding dexamethasone in reducing the course of the disease. And this does make some sense because we know that the joint damage is an immune-mediated response. And dexamethasone will lower synovial concentrations of interleukins, tumour necrosis factor, and metalloproteinases. And in addition, that will decrease the degradation of cartilage, which is mediated by their cytokines. So it is something that needs further investigation and probably needs some very good prospective studies, but there are at least 2 decent studies already out there that have shown that there is probably a role for dexamethasone in managing the acute osteoarticular infection. So the prognosis is usually satisfactory unless the diagnosis is delayed. So prompt treatment, children should do well. But delayed diagnosis results in permanent joint damage and long-term disability. And the poor prognostic indicators are less than 6 months, associated osteomyelitis, and delay in greater than 4 days in presentation for the hip joint. So the incidence of associated osteomyelitis is greater in young infants, about 15%, because of the metaphyseal location. And a suspicion for associated osteomyelitis is warranted in all cases of septic hip septic arthritis in children. So why do you get joint damage? Well, we get joint damage primarily because of bacterial action instigating an immune response. So infection elicits a strong native immune response that causes cytokine release and high T cell activation. This activation is associated with high levels of cytokines, reactive oxygen species, which leads to joint destruction. The cytokine concentrations increase the release of host matrix metalloproteinases and other collagen degradation enzymes, and the joint is further damaged by release of lysosomal enzymes and bacterial toxins. So it's a highly reactive pool of cartilage damaging material. But in the hip, we also have the raise of intracapsular pressure, which impedes the blood supply and nutrient supply of the joint and may cause necrosis. The increased pressure destroys the synovium and cartilage. The proximity of the epiphyseal growth plate to the joint means that direct extension of a joint infection or an osteomyelitis in that site can lead to decreased bone growth or a growth plate arrest. So the hip joint particularly is attacked quite severely from 2 areas. Our differential diagnosis can be as wide or as small as you like, but generally we're trying to sort out these types of things. So what are the sequelae? I think the sequelae need to be broken up into two groups. One is the pathological sequelae and the other is the clinical sequelae. So pathological sequelae are chondrolysis, dislocation of the joint, shoot arthrosis, osteonecrosis and growth arrest. The clinical sequelae is what we see our patients suffer from are pain, contracture, stiffness, as in ankylosis, leg length discrepancy and potentially instability with a septic dislocation of the hip. So chondrolysis occurs because of unresolved cartilage degradation, late presentation and a cycle of joint destruction. So we may actually clear the infection from the joint, but the cycle of destruction has not stopped. And you can see in this case with severe osteopenia and narrowing of the joint space and obviously a flexion contracture because of the rotation of the obturator foramen. And despite our best efforts, heroic hip releases, chondrodiastasis and other things, these joints generally don't survive and they will go on to becoming extremely stiff and painful and may in fact either go on to an ankylosis themselves or be formally arthrodesed or in this case an arthroplasty. And we would be tending in a patient that is a number of years down the track from an infection that if they are clearly non-infected, that we would do a primary arthroplasty, even in younger patients. We now have a series of at least 50 to 60 patients under the age of 16 that have arthroplasty in desperate situations. The results have been good and certainly better than that from a hip arthrodesis that when you take down 10, 15 years later, the patient has low back pain and the takedown is never good as a revision procedure if you had to do that. Dislocation can occur. This is a patient who's presented late. They've already had an arthrotomy and the hip is still subluxated. The drainage tube is still in situ. And you can see from the MRI scan this tense effusion subluxating the joint. And ultimately this joint went on to osteonecrosis and further subluxation as the femoral head dissolved in front of our eyes. And then at this point, the decision about treatment comes down to the clinical circumstance of this patient and whether they have residual disease. Shoot arthrosis can occur, unresolved infection, often associated with osteomyelitis, the metaphysis, and this is generally a non-salvageable situation when there's growth plate damage and the femoral head is severely destroyed, combined with the articular cartilage. Probably the biggest group that we would see would be in Australia would be patients that present well after the septic event, but with osteonecrosis, a short leg Trendelenburg gait, fatigue, and discomfort. And they're a challenging group of patients because we need to make a decision whether these patients should be offered arthroplasty or they should be offered alternative treatments. And there's much debate amongst our orthopaedic surgeons about which is the appropriate procedure to do. Some of our patients who we cannot be sure that the disease has not been cleared, we will then opt to do a pelvic support osteotomy, either the traditional way we do with a monolateral frame, or what we've been doing more recently using a magnetic lengthening nail to do an acute correction, lengthening distally with an open procedure proximally. But this can result in a good stable gait pattern and equalisation of the leg lengths. So the last thing I'll touch on is growth arrest, because growth arrest is something with septic disease can be difficult to predict and very difficult to manage in the long run. This is a patient who had a joint penetration, had a fungal infection, which was very difficult to eradicate. And the main issue, the two main issues was the chondrolysis that occurred from the fungal infection, but the significant delayed growth arrest that occurred both in the tibia and the proximal and in the femur. So in summary, as we've now had two of us speak to you on this, is early diagnosis and treatment is absolutely essential. The hip's particularly at risk and better to drain than wait for diagnostic studies, and the sequelae of late diagnosis or under treatment are significant and produce lifelong disability. Thank you.